Hi, I am Teresa McClain, and this is my presentation regarding obesity in tweens and adolescents with hopes to promote and improve healthy lifestyles with increased education on proper diet and nutrition. Why focus on obesity in children, especially tweens and adolescents? The World Health Organization initially declared obesity a global health epidemic in 1998. Since that time, 1 in 3 U.S. adults is obese, and the percentage of U.S. children who are or at risk of becoming overweight is even higher. Overweight and obese children are 7 times more likely than healthy weight children to be obese as adults. Not only are these children at serious risk for coronary heart disease, asthma, and type 2 diabetes, but are much more vulnerable to face societal stigma, low self-esteem, and depression. Adolescence is a time of rapid growth and development, making proper nutrition and proper diet especially important. A very interesting point found in studies of adolescents is that most perceive health to be mainly related to their physical bodies and the absence of disease. Their definitions mostly encompass being fit, not having an illness, and not being physically restricted, and to avoid health services. This negative definition is in strong contrast to the World Health Organization's definition of health, used since 1948, that health is a state of complete physical, mental, and social well-being and not merely the absence of disease or infirmity. Adolescence is also a time of rapid social learning. Social norms have profound effects on eating behaviors, how much food is consumed, food preferences, and even how hungry we feel. In addition to the risk factors previously mentioned, overweight and obese adolescents are more likely to have significant anxiety, which is strongly linked to binge and emotional eating. Lifestyle habits contributing to our current obesity trend include the convenience and lower cost of fast food, larger portion sizes provided, decreased exercise, and a skyrocketing increase in screen time, video games, and other electronics. Children are beginning to gain weight just as rapidly as adults, creating the same adult health problems and diseases at an earlier age. Unhealthy children in the United States will most likely lead to unhealthy adults later. Children who develop diseases like type 2 diabetes will most likely not live a full life. U.S. national healthcare expenditures related to overweight and obesity increased from $68.5 billion from 1998 to 2008. So it's really a win-win. Let's promote healthier eating for adolescents, which will not only be cost-effective now and in the future, but also promote better lives for our children and slow the obesity epidemic. How do we do this? We need to first think about our population. When designing an intervention for tweens and teens, the following needs to be considered. First, as mentioned earlier, studies have found that many adolescents perceive health to be mainly related to their physical bodies and the absence of disease. In addition, they also tend to have negative points of view about eating healthy, labeling, often erroneously, foods as good, bad, etc., rather than viewing the benefits of healthy eating and what that entails. Focusing on the benefits of healthy diet rather than the risk factors for disease is more likely to motivate adolescents to improve their eating behaviors, reducing the likelihood of overweight and obesity. In other words, promoting positive messages about the many benefits of healthy eating will be more productive than the negative outcomes of an unhealthy diet. Parental involvement is key. A potential strategy in fighting obesity in children and adolescents is to develop health promotion interventions that improve parents' capacities for managing their children's diets. Most importantly, a successful intervention with our tweens and teens population needs to be fun and appealing to children. Why do adolescents choose to eat poorly? Looking at the theories we have reviewed in class, we can attempt to understand why this behavior occurs. One that seems applicable is TPB, Theory of Planned Behavior. Social costs are a strong determinant of behavior change, and going against social norms is seldom easy. We can understand how eating poorly is contagious with peers. It's difficult to maintain a positive attitude about eating healthy when vending machines and fast food restaurants are much more affordable, especially to teens with limited incomes, their perceived behavioral control. Plus, fast food and sugary beverages taste good. You don't often hear kids and their friends asking to go out for salads. Most often it's for pizza and burgers. The second theory that seems most applicable to understanding poor eating habits with this selected population is the health belief model. Inconsistencies often exist between beliefs and behaviors, especially when it comes to dietary habits. Most people understand when given a choice of eating an apple or fries that the apple is considered healthy, but the desire and often the availability of fries seems the more prevalent choice. Perceived threat and susceptibility create low feelings of threat with this population. Most overweight or obese teens have not yet experienced the likely symptoms or onset of disease. Some successful interventions aimed at children in obesity prevention over the years include the very popular Let's Move campaign led by Michelle Obama. The program is internet-based, divided into 5 sections of information: learn the facts, eat healthy, get active, take action, and join us. The material is directed to children, parents, and caregivers, applying the EPPM model in that 1, it uses fear appeal informatively, clearly stating the threat to our nation and children, and 2, encourages efficacy and motivation for families to gauge in realistic solutions for fighting obesity. The Eat Healthy section also provides a link to the ChooseMyPlate.gov website, operated by the USDA, which offers simple, straightforward information in a variety of outlets to educate us on how to eat properly, information which is assumed most know but in reality is often misunderstood. Another successful study was more so aimed at creating a foundation for health promotion interventions by effectively applying the theory of planned behavior to identify perceived challenges faced by parents in providing their children healthy diets. Normative beliefs far outnumbered the presence of attitudinal beliefs. The authors felt that this was possibly due to past communication efforts successfully shaping positive attitudes toward healthy eating. Proving conflict was the recurring barrier. Viewing perceived control, the barriers range from differences in health-conscious actions among family members, for example, mom enforces eating rules, dad breaks those rules, family traditions, and ultimately the lack of time and financial pressures. One very powerful message found in the article about interventions, encouraging cooking meals at home, touched on teaching food preparation skills as well as providing nutritional benefits. As one parent noted, the reliance on prepared foods could result in a generation of children who lack food preparation skills necessary to maintain family traditions and family socialization, in addition to eating well. It was a surprise to learn, at least based on the obesity research that I found, that social cognitive theory was only somewhat successful when applied to childhood obesity programs. However, the articles reviewed had several external barriers, many as a result of environment of study. For instance, one study was conducted at an after-school program which was difficult to measure consistent variables when the children were picked up by parents at various times. It would seem this theory would be successful in promoting childhood obesity programs, and perhaps that would be the case if all 5 key constructs of the theory, knowledge, perceived self-efficacy, outcome expectations, goal formation, and sociostructural factors are emphasized and studied in a measurable environment. Proposed intervention strategies to apply to the health behavior of eating healthy are as follows. First, determine both parents' and adolescents' nutrition, knowledge, beliefs, and attitudes in regards to healthy eating. Second, educate the benefits of a healthy diet and lifestyle and broaden the definition of health to include physical, emotional, mental, social, and spiritual aspects. Third, provide this education in a fun, interactive environment engaging to an adolescent audience and their caregivers, such as a convenient, easily accessible phone app, including games to enforce healthy eating concepts, a point system for fun family rivalry, and opportunity for rewards related to a healthy diet. For example, at our house, winners often get to choose or help cook dinner that day, something we actually consider fun at our house. Using the key barriers found during research that inhibit parents and children from eating healthy diets, the most popular being lack of time and financial pressures, Use this information to formulate realistic, achievable goals while acknowledging additional benefits other than nutrition in order to increase self-efficacy. For instance, sell the fact that eating healthy has other rewards, like cooking, gardening, or shopping together. Or use the money saved by meal planning and preparation to plan a family vacation in a year. Using the theory of planned behavior, we can effectively predict a baseline of current knowledge and barriers that adolescents, tweens, and their parents have in providing healthy diets. Using social cognitive theory, we can then expand and educate on the broader definition of health, encompassing more than just physical body. We can build self-efficacy and outcome expectations by delivering the information in a fun, informative manner, highlighting the short-term benefits of eating healthy to eventually experience the long-term health effects. Establishing realistic goals is a foundation to build future goals, like starting with preparing one healthy meal at home per week if accustomed to eating fast food most nights, then proceed to 2 meals per week as the behavior is more understood. Most importantly, take into consideration schedules, etc., and how to prepare for expected barriers. If a teen has finals all week or practice every night, have prepared sandwiches or wraps on hand with washed fruits and vegetables easy to quickly pack for on the go. And hopefully they will avoid the drive-thru or school vending machines. If you're a single parent and know you have a big presentation due next week with little time to cook weekday evenings, when making dinners or cooking that weekend prior, prepare extra and freeze, using microwave steamable frozen vegetables as a fast side. There are a few possible ethical concerns to take into consideration with this type of intervention. First, privacy. Obesity is in fact a medical condition, and as such, the diagnosis is considered confidential. Using health promotions directed at all adolescent populations, not just those overweight or obese, may be viewed as a more ethical approach to the public. For cultural and family traditions, eating is very social, and our environment is a stronger influence on our eating habits than most probably realize. We need additional protection from an unhealthy food environment. Government policies, even starting as small as enforcing limitations on sugar and sodium content at restaurants, could have remarkable benefits for the public in a few years, especially for the adolescents that frequent these establishments. This concludes my presentation. Thank you very much for watching.